All right, thanks for having me this year. This talk's going to kind of go on a little bit more into the role of the inner body specifically for degenerative conditions. Certainly one of the roles of the inner body is to provide an environment conducive to fusion, which we just touched on, which is great. Here's some of my disclosures. I'm going to start with a case. So this is a 45-year-old guy, back and leg pain. He's 6'3", he's 230, so fairly muscular, but not obese. He's a smoker. He's tried numerous injections over the years with intermittent relief of his leg pain. Still central back pain with standing and walking. Actually had bleeding ulcers from NSAID use, pretty severely debilitated. Here are his x-rays here. You see 4 or 5 spondy. Look at his MRI. You guys said degenerative, so we got a 1 level 1 here. Here's 4 or 5. Again, fluid in the facets. So you look at and we're thinking inner body, so we'll kind of think about where you would want to go with this one. If you look at the psoas, maybe favorable for lateral. Crest, maybe a little high for a lateral. Some people would probably try to overcome that. Foraminally, he's got some stenosis there. So what are some of the options? Who would, for this particular case, do something all posterior, maybe show of hands? Okay, so TLIF or PLIF or something along those lines? Okay. Even in a smoker, you're good with that one? Get a good open? Are you going open or MIS? Who's going to do MIS? MIS TLIF or so? Okay, all right. And then how about the lateral? Who would look at this and say, I don't know, maybe this is a good case for lateral? No lateral interest on this one. When you look at that, what is it? The crest that's sort of the main deterrent? Who thinks crest is sort of like too high for me? All right. Well, anyway, so the right answer was a 360 fusion. No, I'm just kidding. So what I did was a 360 for this guy, and the reason for that is just to highlight the role of the inner body. To get the indirect decompression is mainly foraminal stenosis. He had a little bit of lateral recess, so we were able to get that just with the indirect decompression. Also, muscular guy, I don't really want to do a big open posterior surgery on him. I'd rather get it all from the front. He's a smoker too, which you pointed out earlier. I think the ability to use BMP2 in this particular case, get a higher fusion rate through a larger inner body, and then limit the posterior disruption to just 2 Wilty incisions for perk screws. So that was the result for that guy.
Question.
Yeah.
Why you didn't do oblique?
That's another option. I've tried that once. I'm not there yet. I think I need a little work on that one. But I think that's a great option. There are a lot of people who would say that's a great OLIF case. Do that. For me, the OLIF I just have a hard time with doing something more anterior based in a lateral position. Every time I've tried it, I've been like, I wish these patients were supine so I could, I don't know, that's just me. But I think another great option. So in terms of the inner bodies, they can be placed through a variety of different approaches. They've been indicated for degenerative pathologies, trauma, deformity, tumor, infection. Anterior, oblique, lateral, transfemoral, posterior, those are all the options. There's even roadmaps that'll guide you there with arrows, tell you how to get there. Papers have all described the pros and cons of all of them. I think we all know all the risks and the pitfalls and the benefits of each one. And the key to this is just picking the right approach for the patient. So the role of the inner body, in addition to providing an environment conducive to fusion, would be that getting a higher fusion rate through an inner body. Indirect decompression of neural elements, sagittal correction, coronal deformity correction, and then reduction of spondylolisthesis. Looking back at the history briefly, in the 1880s, the familiarity with the anterior approach to the spine was really developed for tuberculous abscesses. And so the first inner bodies were anterior, and this was in the 30s and the 40s in Burns and Kapaner, a tibial peg through L5 on a younger patient. In the 30s and 40s, those procedures were sort of further refined. The approach was refined a bit more. This is from Mercer's textbook. You see taking a piece of crest and just putting it in there by hand along with another one into 5-1. I love that picture. Watkins, Wiltses in the 50s and 60s sort of transitioned everything to posterior lateral fusions, and I think for a long time that's sort of where things stayed. In the 50s, Clower described the PLIF. You got indirect decompression there, so that's kind of the first case of that. But high rate of neurologic injury, dural tear, et cetera, people kind of went more posterior, non-inner body. 80s, TLIF comes along. And then you get trans-psoas surgery, MIS approach further defined in the 2000s, AxioLIF, brief appearance, although still alive and well in some parts of the country, believe it or not. OLIF is newer. But I think in general, if you look around the country, most people are doing TLIFs and they're doing PLIFs. And really that sort of spawned from increased, or improved instrumentation rather in the 90s, and so really there was an increased use, and people have sort of continued to use it because it's familiar, it's well studied, there's good results with all the different papers you look at. But I think the adjacent level disease, the amount of pseudarthroses that you see out there, especially from these small peak cages, it's created an environment rich for revision surgery, especially the lateral surgery at 3-4. I think everybody probably sees a ton of that. And so I think, the question is, are you really helping people by doing a T-lift with a small cage? My opinion is it's not. I don't think we're helping people unless you're really, really doing everything right, trying to, everything possible you can, or if it's a last resort. And a lot of times it is kind of a last resort. You can't do a lateral, you can't do an anterior, maybe they're too obese, or for whatever reason.
But did you start out doing T-lifts and went to A-lift, or?
I started out doing both, but I definitely did a lot of anterior all through residency and then all through fellowship at TBI, so I'm kind of biased towards the anterior surgery. But I see a lot of patients like this with a 2-level T-lift, severe adjacent segment disease. I didn't include all of her imaging of her laterals after this, but that's, you may say, well, that's just like your opinion, man. But yeah, that's my opinion. So case number 2, this is a 70-year-old guy, back and leg pain, otherwise pretty healthy, pretty active. Here's his images here. So you look at his images, no real coronal issues. He's got a 5-1 spondy, real severe degenerative changes at 3-4 and 4-5. If you look through his MRI here, real degenerative, foraminally just crushing stenosis, really at all levels, 3-4, 4-5, 5-1. Same on the other side, more so 5-1. Here's L3-4. Here's 4-5. And then as you'd expect, here's 5-1. So looking at that patient, who's, again, thinking all posterior for this guy, or what would you do, I guess?
Could be an option, all posterior MIS T-lift, or I could do an all lift 3-4, 4-5, and then T-lift 5-1.
Yep, I like it. But everyone's thinking.
I have a question.
Yeah.
Where is pain coming from?
So he's got central back pain, standing, walking, very consistent with his spondy at 5-1. He's got bilateral leg pain. He's undergone epidurals, multiple epidurals over the years, targeting mostly transforaminally. I think he had a caudal most recently, which gave him intermittent sort of short-term relief of his pain. So I think it's back and leg pain for sure.
But is it just 5-1, or do you actually think it goes all the way up to 3-4?
Good question. So that's what would.
Where's the leg pain?
So he's got his radicular pain it's consistent. I mean, it's mixed, but it's definitely L5, definitely L4. He doesn't necessarily have severe thigh pain, but he does there is some more proximal pain in there as well. It's definitely radicular pain. It's gotten better after epidurals. I don't think this is
What we do in our practice lots of times for something like this is a selective L5 nerve block, which bilaterally transforaminal and gives you a true sense of, is that pain coming from the L5, is McSpondy. I mean, obviously, also discussing where the pain's coming from,
Right.
what position, standing, walking versus sitting, and alleviated with sitting, because obviously a 3-level fusion versus a 1-level fusion, depending on the age of the patient, just the morbidity of the surgery.
Yep.
But really, in my hands, is the adjacent level disease with a 3-level anterior posterior fusion. We're starting to look up that series in our group with 5 surgeons, and it's extremely high. And so, if I can avoid a 3-level anterior posterior fusion, I try to at all costs. And I kind of explain to the patient, hey, let's do a 1-level fusion and kind of see where you go from there. And so, in my hands, doing that selective nerve block bilaterally will allow you to isolate sometimes if they're getting significant pain relief with just that alone, that this is more due to the instability and the spondy at 5-1.
Yeah, but is it okay to stop?
Yeah, that's what.
5 with looking that way, even if it's not the current pain relief? I would do a 5-1 A-lift here and then posterior 3-1, possibly a T-lift at 3-4.
Yeah.
I agree with, by the way, what you said about shying away. I've started doing less and less T-lifts and more T-lifts if I really need it, but that 3-4 is a good level, I think, for a T-lift. Versus the 4-5, like if he does a T-lift there, it's going to be completely ineffective.
Yeah, and one other thought is just this foraminal stenosis here at 4-5 is pretty severe. So I think that was one that really kind of put me to the 2-level And then do you want to try to decompress alone above the, I don't know, looking at that really severe 3-4, mainly right-sided disc collapse, etc. I kind of, yeah.
But you said he doesn't have specific right thigh pain.
He's got both legs, bilateral leg pain.
Do you have flexion extension?
I do.
3-4 is going to be very stable.
3-4 is fixed on flexion extension. 4-5 does not move on flexion extension. 5 won't slip.
It seems that with the deformity of 5-1 that's been there long term, you've already tested the instability of 3-4 and 4-5. So you could really get away with one level fusion without a lot of adjacent segment.
And then decompress.
Just decompress level. Yep.
3-4, 4-5 decompress.
I'd stick with one level.
Okay.
All
All right. I think that's definitely totally valid.
So if you do a positive select nerve block L5, that's negative, go to L4, if that's positive.
Yeah.
Then you have more information to do additional level.
He had actually had L4 nerve root blocks. My thought was 5-1 is a for sure fusion level. So he had undergone epidurals at 3-4, 4-5. Certainly 4-5. 3-4 I think he had, but I don't know for sure. I'd have to look him up. But anyway, I think those are all good options. But again, the right answer for this one was a 3-level 360. Just kidding. So that's what I did. And my thought there was I just didn't want to come back for 3-4. It was too hard to tell where is this pain coming from. And again, I thought by getting all indirect decompression, because most of his issues were foraminal stenosis, I was able to limit this again to percutaneous in the back. So
how did you decide a 3-level with symptomatic foraminal stenosis preoperatively? When do you perk in the back, and those right-sided foramen pretty tight?
Yeah.
Versus when do you have that confidence to get indirect decompression versus doing a direct decompression?
Yep. So if I'm able to get this kind of indirect decompression where you can really see if I get really good mobilization in there of the disc space, then I'm pretty confident about that. I staged him though, so I just came back. I assessed him the next day to see how he's doing, and he said my leg pain's gone. So at that point, I do perk. Now, if there's any question still, or if they've got real severe lateral recess, or if there's certainly any central, then I just do it open. And that can be done in a variety of ways, whether you do it open or you do 1 incision with perk screws and then little laminotomies, or 3 incisions. So a lot of different ways to approach it.
I agree with that. Sometimes even with multiple laterals or interiors, I'll stage those for that exact reason. I don't think I've ever actually found that they had persistent pain and actually did an open decompression, but it made me feel better about it. And trust that I get away with it.
When do you feel like you can do that? I mean, like Sig said, I have a hard time when I have someone that has up-down stenosis from degenerative disc disease and it's mostly disc height loss.
Mm-hmm.
I feel comfortable with an indirect decompression, but when, like in this gentleman, I'd have a hard time not doing some sort of foraminotomy, especially at 3-4 on the right side where he's really collapsed down, and the facets are bad. So you have the facet arthropathy causing some lateral recess as well as foraminal stenosis.
Mm-hmm.
I don't want to have to come back. So I guess your answer is to stage it.
Stage those, yeah.
And to see how they do, and you get them up with the 3-level standalone and walk
Yeah.
them a little bit that next day, and then make the determination.
Yep.
And also for me, in some of those cases, if they get great rest relief, so on their own, if they're indirectly decompressing themselves by when they sit down
for 5
they get
minutes.
100% relief. I've never seen them not get relief from an indirect decompression. But if they have persistent pain, if I sit more than 20 minutes, I start to get leg pain again, or I don't really get complete relief, then I'll usually just do some kind of open decompression.
I just have a hard time not decompressing while I'm there.
Yep.
When I do the obliques, I also stage. My stage is Monday do the oblique, and Tuesday reassess, do an MRI to see the indirect decompression. On Wednesday we'll either go back in, and usually I will go back and decompress, because I want to be 100% sure that the purpose of the surgery was decompression.
Yeah.
And I want to be 100% that I deliver that to the patient. The question to you, guys, that's thing that a patient pain go away. When you stage, you also wait 1 day. How do you know that all the narcotic, the anesthesia, I mean, they have so much pain in the back. How do you know that what she's telling them, oh, I don't have leg pain, is really true?
You do have to see them and make that assessment. So a lot of that depends on the patient. If they're up walking around and they've been on minimal narcotics and they're telling me sometimes more reliably, like, hey, actually I'm feeling great now. Okay, good. If it's indeterminate, then definitely err on the side of doing the decompression. That's how I do that one.
I think that's really a leap of faith in every
Yeah.
upper level, but looking at some of these invasive readings, there are people who take not just foraminal stenosis, but a blacked out central canal and do laterals and perk screws.
Mm-hmm.
And from what some of the literature, some act normal, some not, is that the risk of you going back to actually do direct decompression is very, very low. There was a part of my career, a few years ago, where I did multi-level laterals and perk screws. Either stage or all together, but you're absolutely right. It's really hard to tell.
Yeah.
They're all groggy and kind of, what's what. But I can't remember the last time I had to take somebody back to actually do a laminectomy.
Some of the thought process is if you sit and your leg pain goes away, the concept is that if you can go anteriorly or laterally and distract, you should get a similar result. And so some people use that as a preoperative testing, that if they have no leg pain with sitting,
Yeah.
then you can feel more confident that doing an indirect decompression will be more
You
beneficial.
don't need much, right? We're talking like, the
Yeah.
last millimeter or 2
Right.
millimeters.
Right.
Because you see people with severe stenosis all the time that are asymptomatic until that last little bit, and then all heck breaks
Yep.
loose. So
Oh.
you're just trying to recreate that, getting back that last millimeter.
Yep.
The other part I would say is that, especially on some of these more degenerative patients, when they've got that 3-level central stenosis that's critical, if you stage them, you can maybe just do a LAMI at 1 level rather than a big open midline 3-level LAMI and screws. So maybe they post-operatively have only isolated L5. Now you can just go in and decompress L5 rather than all 3 levels.
Yeah. The other thing too is if you see a high-grade spondy that you then reduce, that's another one where you get that blacked out central canal. You can really indirectly decompress those with the spondy. Without the spondy, it's really, I'm only looking at the foramen. What can I get foraminally? Because you're really not going to get much lateral recess and certainly no central there.
A lot of time what I do, I will go just through a tubal retractor, go put a tubal retractor, do a laminectomy from and just perk
Yeah.
screws.
Another thing too is if you're planning on doing it all at once, you can have that discussion with them and say, look, if we can do the surgery this way, you're going to have minimal soft tissue disruption on the backside with the perk screws. If we need to come back, it would be a small incision, it'd be a laminotomy through a tube, right? So I think if you preoperatively, if you talk to people about that and you kind of outline the risks, you'll find some people are more willing to do that. Some are not. They're going to say, no, I want it done. I want it all done. I don't want to come back one and done. Well, then err on the side of an open decompression.
Have you looked at your complication rates when you do ALIFs at 3, 4, 4, 5, 5, 1? Because for me, my complication rates, the higher I go from the front, really skyrocket.
From 5-1 being the lowest, and
5
then
being by far the lowest,
Yeah.
it's a great observation.
Yeah.
4, 5 being worse, 3, 4, a whole slew of things. Like one time I got horrible lymphedema of the legs, higher sympathetic disruption. I mean, it's still a great operation. And
Yeah.
I completely subscribe to the way you did this. And I think that indirect decompression, I've been a huge convert to it because I think it's in fact almost better than,
Yeah.
maybe even more predictable than the way you did that last one. Anyway, have you looked at the complication rates? I'd be very curious about that.
They're basically the same for me. I've had, knock on wood.
We published on that, just very briefly, Chuck Eichler and I published on that 1,200 cases now, where there is a bit of an inflection point with regard to levels, and specifically with regard to postoperative ileus, so a bit of an inflection point, yeah.
Anyway.
Let's just-
All right, we got the last one real quick. 46-year-old, she'd had a prior 4-5 decompression. She tried injections at 4-5 again, actually 5-1 and 4-5, targeting both. But issue here is this is highlighting the role of the inner body for a coronal deformity, for a scoliosis here. So what are some of the, I guess we'll just get to it, huh?
Yeah.
So for this one, my thought was, I think there's a lot of different ways you could do this. You could certainly do this with a T-lift. You could certainly do this open. But I did want to correct the curve. The curve did progress a bit since her decompressive surgery alone. You see here, 3-4 is fairly normal looking there. 4-5, she had this recurrent disc herniation, and then she had this ongoing stenosis there. Foraminally, she's stenotic at both levels. So for this one, and then the psoas was favorable for both those levels, fairly small psoas. So for this one, this was a case, where I did a lateral, 2-level lateral. And just with the inner body, and then those are again, perk screws, was able to get that coronal and that rotatory correction, which oftentimes you think you have to do a T-lift to get that, but this is a case where it didn't have to be done that way.
Can you go back to the preoperative?
Yeah.
And only because you're up there, Sig, I've had this discussion in my mind about patients that I see with standing films like that have pelvic obliquity, and whether or not I should correct the curve or
Yeah.
leave them somewhat curved. You know, if they don't have a fixed.
She
leg
does have a
discrepancy.
limb length discrepancy, yeah.
Yeah, is the belief to, you know, if you're doing 2 or 3 level fusion, should you correct that to a perpendicular to the pelvis and pitch them off to that side, or do you leave them with a soft curve and?
Yeah, so I think it depends on whether or not it's a true pelvic obliquity or an apparent one, right? So she had a limb length discrepancy.
She does have a
so
slight limb length discrepancy,
it's-
but
it's
you look
interesting.
there and her pelvis is more level.
Yeah, it looks pretty level there, that's why.
Yeah.
Yeah, so I do, since we have the limb length discrepancy, I'd actually level the limb, just like we would in a pediatric case, level the limb preoperatively with the block, and then typically I'd go perpendicular from there.
Okay. But then if you do that if they don't wear a shoe lift, then their leg length discrepancy is gonna cause your correction to always be pointing off to one side, which is gonna increase your adjacent level risk.
It's an important problem. So, you know, a subset of patients who truly get a limb length discrepancy, so if somebody's got a pelvic obliquity, oftentimes correcting their deformity is going to correct their obliquity, which is maybe what happened here.
Right.
But if somebody's got truly a limb length discrepancy, then that's a discussion where, you know, in general, I'd like to try and do something with the limb length discrepancy. Sometimes we have the opportunity in older patients who can have a hip replacement,
Yeah, do
to
both.
even talk to the hip people about that and maybe get some change in the limb lengths with that. But yeah, there are scenarios where maybe going perpendicular to perpendicular to the floor, leaving the pelvis oblique, so you end up with a UIV that's horizontal. There are some scenarios where when you fuse to the sacrum that might make sense.
Okay.
Yeah. If you leave more levels to allow the correction, like this, limiting it to 2, you're allowing those other levels to compensate
Right.
if needed. She also did have a lift that she started wearing, so anyway. Yeah.
When you don't
Kinda
fuse to
did
the
both.
sacrum, you get a lot more flexibility. When you fuse to the sacrum, that's a
Yeah.
really, really important point. We're gonna try and get through 3 more,
Yeah.
thank you. Great cases, great cases.